G'day, I'm Ted Jedinak, creator and facilitator of the internationally acclaimed and accredited Foot Mobilisation Workshops, published author and founder and director of the Foot and Leg Centres in Australia. I help health practitioners just like you master new treatment options so that you can have the best tools for better clinical outcomes. It's all about giving you effective choices that fix the problems you see in your clinic every single day. Why are plantar heel pain results so variable? I mean, even after conscientious assessments and treatments, are you still wishing or hoping that your patients get better? I sure felt this way a lot of the time. Many of my patients would get better, but not best, and I didn't understand why or what I could do about it or how I could fix the problem once and for all. Danny was a classic case. An electrician, approximately 40 years of age. Danny came to us thoroughly frustrated by the results, or lack thereof, that his physio and podiatrist had achieved. They'd combined some massage, including dry needling with orthotic therapy, but these options just hadn't resolved Danny's problem. Danny reported about 75% improvement before hitting the glass ceiling. His progress would plateau despite the best efforts of his physio and podiatrist. They were scratching their head and they'd run out of options. Danny's presentation was typical. He experienced pain on rising in the morning and after rest and after the day's end. And he'd had about a 12-month history of heel pain. His wife told him, "Stop bitching and come and see us." Now, as a self-employed Sparky, Danny was really worried that his livelihood was going to suffer. Climbing ladders, crawling through roof spaces, they were becoming more and more difficult. He actually noticed that he was turning down certain types of work because ladder climbing in particular would stir things up. Now, Danny had had ultrasound and massage by his physio and also some dry needling in the foot and calf. And the typical foot and calf stretching exercises were also included. His podiatrist provided semi-rigid EVA orthoses with cushion top linings. It even had some low-dye strapping, and it was quite successful in the short term. It was when his physio suggested cortisone under ultrasound that he thought, might be time to change tack, and that's when he came and saw us. Danny was one of those cases where things got better but not best, and no one could explain why. Danny's frustration stemmed from not knowing why he had this problem, and as well as why the painful symptoms kept persisting. It was really wearing him down, physically, emotionally, and mentally. He really wanted to know why his problem wasn't getting better. We found out that the true cause of Danny's problem came from an anterior displacement of his talus. This was confirmed by weight-bearing plain film x-rays. Talus displacement meant that the medial beam was shifting anteriorly relative to the lateral beam, increasing the tissue tension on the plantar fascia. None of the treatments Danny had had with other practitioners had addressed this factor. When we did our biomechanical assessment, Danny scored a 2+ on a 4+ scale of foot posture. It didn't look that bad as far as degree of subtalar and mid-tarsal pronation went, but as we know, that's not a reliable indicator, is it? On palpation, it was the proximal third of the medial band of his plantar fascia that was particularly sensitive. Felt a little bit irregular, and considering the chronic nature of Danny's problem, not so unusual. I then used this tool, which is a stainless steel device for tool-assisted massage, and it breaks up the irregularities in scar tissues. But first, I use this tool to assess the fascial tissues. Now, as an assessment tool, it amplifies any irregularities and it helps identify the specific structures that need releasing. It also saves your fingers and thumbs from wearing out. Now, there was a distinct difference in the quality of the fascial band and the proximal third compared to the rest of the band. Fascial release work on this area facilitated healing and it restored this part of the fascia. Now, in chronic cases like Danny's, we do a fairly intense blitz of treatment because of the avascular nature of the fascia. What this means is we will see Danny twice weekly for 3 weeks and then reassess. The treatment itself consists of about 10 minutes using the fascial releasing tool. First, you establish a baseline by doing a few light pressure passes over the area to gauge the level of irregularities. They're kind of like corrugations that the tool picks up. Then you do 30 seconds of passive firm pressure passes and then another 30 seconds of active firm pressure passes. Then you do a baseline testing again and notice the change. Typically you'll achieve about 50 to 80% improvement with each treatment, especially in the early stages. In the second and third weeks, the changes are more subtle because of the gains that you've made and the overall improvement. In Danny's case, after 3 weeks of treatment, his symptoms were completely resolved. and that's pretty typical in about probably 90% of the time. Those more stubborn cases usually graduate to weekly treatments for another 3 weeks to get full resolution. We also included some posterior talar mobilization treatment to help reset the talus back home to reduce the pressure on the plantar fascia. Now, the first few sessions, Danny's wondering what he'd done because we'd actually stirred things up a fair bit. And that's because microscopically we were tearing apart the fascial restrictions, and you know what? That can hurt. So we incorporated some gentle ice bottle massage as part of Danny's treatment and his management. Good news is, 3 months later, Danny is still asymptomatic. We got him doing some self-massage exercises using the dowel, or as you guys say in France and Germany, the stick. We also advised him to keep wearing his orthoses in his work boots. At this point, we'll check up on him in 6 months' time, unless anything untoward happens, but I'm not expecting anything out of the ordinary. So, this is what we can learn from Danny's case. 1, plantar heel pains or plantar fasciitis commonly get better, but not best with conventional treatments. 2, anterior displacements of the talus, they're pretty common and can add to the tissue tension of the medial and middle bands of the plantar fascia, and if left untreated, your results are going to suffer. 3, tool-assisted massage can be really helpful for assessing and treating fascial compensations without stressing your fingers or your thumbs. 4, sometimes you have to be cruel to be kind to help these chronic conditions involving fibrous fascial tissues. So that's how this fantastic tool can help your patients progress even further. I wish I'd learned about this at university. I could have helped so many more people. It's a tool now that I wouldn't work without. It's invaluable. I hope you'll now be able to help more people with their fascia-related problems like plantar heel pain, Achilles tendinopathies, and shin splints. Hey, if you're watching this on YouBook or FaceTube, please hit the like button if it's been useful to you. And if you think a colleague would benefit from hearing this stuff, please share it with them because it means that they'll be able to consider more options, especially for patients with plantar heel problems. Until next time, serve with spirit, consult with care, and tool up today.